Assalamu alaikum. So I welcome all of you to free paper 2. So the first one is I would like to ask Dr. Nematullah, palliative home visit, a team-based comprehensive approach at doorstep.
Assalamu alaikum. My name is Dr. Nematullah, palliative resident SKM Peshawar. Today I'm going to discuss about palliative home visits, a team-based comprehensive approach at doorstep. So what is palliative medicine? According to World Health Organization, it's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain, illnesses including other problems, whether physical, psychosocial, and spiritual. So palliative home care services at Shaukat Khanum Hospital. The objective of this study is to evaluate the effectiveness and comprehensibility of a team-based palliative home care service. The key components of the study are symptom evaluation, medical management, patient and family education, psychological support, and followed by QPHD survey. So the methodology in this study was a retrospective observational study in which we observed 90 patients over 8 months period. And the data collection are from patient records, which is HIS system and QPHD survey. So benefits of palliative home care services. Personalized care in a familiar environment. It's an individualized attention and comfort of home reduces anxiety and promotes relaxation. Effective symptom management, real-time assessment and management of symptoms ensure timely interventions. Enhance quality of life, addresses physical, emotional, social, psychological, and spiritual needs, significantly improving life quality. Family support and involvement, encourages family participation, providing them knowledge and skills to support their loved ones. Reduce hospitalization, decreases unnecessary hospital visits and admission by effectively managing symptoms at home. Cost effective, reduces the financial burden associated with frequent hospitalization. Continuity of care, regular visit foster ongoing communication, proactive management of issues. Palliative helpline integration facilities care through remote check-ins and adjustment to treatment plans. So preparation before a home care palliative visit. There are selection criteria for home care services. Patients are selected at the emergency assessment room, clinic, or inpatient department and by palliative helpline. Patients selected based on needs, preferences, and not limited to end-of-life cases. Understanding the referral, clarify the reason for the referral and specific objectives of the home visit. Gather any relevant background information that can guide the approach. Medical information review includes patient history, current conditions, medications, and directives. Essential supplies, medications, symptom management tools, PPEs, and educational materials. So during home care visit, the physician are conducting an assessment in which initial assessment conduct a thorough assessment of the patient physical, emotional, and social needs, evaluate vital signs, pain levels, and any other significant symptoms. Pain assessment and management, utilizing pain assessment tools to evaluate the intensity and nature of patient's pain, adjust prescribed dosages based on the assessments. Other symptom managements like nausea, dyspnea, and constipation, and management through appropriate interventions. And assessment of nutritional needs are also checked, and finally, consultant discussion, which is vital for providing specialized expertise, enhancing symptom management, and ensuring a cohesive care plan. So conducting medical procedures at home, in which wound care, medications, respiratory care, stomach care, urinary catheterization, and nasogastric tube insertion if needed, and laboratory investigation and sampling. After the home care palliative visit, documentation, records patient progress and update care plans. Communication with care team ensures all involved healthcare providers are informed of care updates. Follow-ups, which are scheduled follow-ups via teleclinic or helpline based on patient needs. Patient and family support provides resources for symptom management and emotional or spiritual care. Monitoring and feedback suggests logging symptoms and encourages feedback to improve care quality. So this is a brief summary. As we discussed, patients are selected via clinic, ER or inpatient department or through palliative helpline. Then preparation for home visits are done. And then after that during home visit, there is detailed assessment, consultant discussion and relevant managements. And post visit, the documentation, follow-ups and monitoring and feedbacks are done. So this is the QPSD survey regarding palliative home care services, which showed overall high satisfaction rate, which is above 90%. So the conclusion is the service effectively managed patient symptoms, provided a holistic approach to patient needs, combined symptom evaluation, medical management, education, and psychological support, achieved high levels of satisfaction among patients, and followed by QPSD survey confirmed the quality of service, and future enhancement will focus on improving patient and caregiver education and adapting care plans to evolving needs. Thank you.
Thank you. So one question I'm going to ask.
Yes, sir.
So what are the challenges you face in the home visit?
Sir, the challenges are the doctors face the challenges of communication with consultants. Sometimes there is no communication and the traffic, and sometimes we visit to a remote area. So that those communication like security and these problems we face sometimes.
Dr. Nemeth, you finished well in time. Very good for that. I just have one question. Do you think in your setup where you work, do you think you need more workforce for this kind of facilitation?
I think we need more work for this facilitation because for now we are covering an 20-kilometer radius from SKM in Lahore and Peshawar. So in 20-kilometer radius, there are not so many palliative patients, and there are so many palliative patients and other like outside Peshawar or outside Lahore. So we need some uh,
Okay,
facilities for them.
At the moment, how do you prioritize the patients?
So we prioritize the patient. Either patient come to emergency room, either come to clinic, or mostly patient call through our palliative helpline. So when they call, we discuss the case with symptoms and case with our consultant. And during that discussion or in MDT meetings, during that discussion, we prioritize the patient. Either this patient need uh, emergency home visit or these patient needs later on home visit. So then we plan the home visit according to that.
Okay, thank you so much.
Thank you, ma'am.
Okay. So our next talk is on palliative, sorry, that's done. Buprenorphine effectiveness in cancer-related pain by Mohammad Shahryar from SKM Peshawar. He's not here. Okay, so then the next one is toward overcoming loss, building effectiveness, bereavement, support service in tertiary care hospital, and this is by Asma Nahid from Indus Hospital.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Asma Nahid. I'm a psychologist, palliative care psychologist at Indus Hospital in a palliative care team in psychosocial department. My topic is towards overcoming loss, advancing bereavement support in tertiary care settings in LMICs. So the need for bereavement support, we often witness families go through different challenges, struggles, and emotional sufferings when their child is diagnosed with cancer, from the day of the diagnosis until the death, and even after the death. So because they have the intense emotional suffering period, they need a lot of support in their journey. But most of the time, whenever there's a death in a family or of our loved ones, we feel pain. But if the death is traumatic or it involves a lot of suffering, it magnifies the pain. It's just like a cancer. So cancer has a long journey of intensive suffering. Unfortunately, Pakistan doesn't have a structured bereavement support care services for the one who have lost child, and particularly for the cancer patients. And many families are left without emotional and psychological support during their darkest hours. So this gap can prolong their grief and worsen their emotional sufferings. And when we were to get to know about these families, and when healthcare team members get to know about these sufferings, they don't often have the solution to that, and they struggles that how we can support these family when they are suffering. As a psychosocial member, we get attached with the patients, and when we used to think about then how their parents are coping with the stress and the loss and how they are doing, so that's what we started from this curiosity that we should connect with parents and their families, that how they are doing. Why we want to focus on bereavement care? Because providing the and the provision of continuity of care would make the families feel that they are still connected with their loved ones. As I mentioned, that the families and the patients suffered from a lot of emotional experiences and painful experiences. And luckily or fortunately, as healthcare providers, we are the one who witness their journeys. They are the one who are in the hospital in their vulnerable times, and we are the one who are providing support to them. Their relatives, their friends are not there to witness that journey. So the emotional connection is very strong and is very well developed at that time. But unfortunately, when a child passes away, that connections kind of abandoned. And families and even ourselves, we want to get connected to the person we are grieving, that who would understand us more. And as a healthcare providers, we can understand them more. So continuity of care, make sure that they are not abandoned. They develop trusted healthcare system, that they are still being taken care of. It helps them in easing their emotional trauma and preventing complicated grief. Holistic approach, and it provides the support to caregivers and enhancing closure. So bereavement care services does not involve the services I'm going to be mention. It has the legacy building, it has the letter writing, it has the making the memories. So these all services make them help to have a closure when their loved one passes away, and in return, it helps them to improve from there or to go through their grief process. So grieving parents need structured and compassionate support. Our initiative aims to fill this gap and provide a pioneering model for Pakistan, so creating a bridge between loss and healing. Our responses. So our project is divided into two phases. At first, we had this curiosity that how the families are doing, because as a healthcare provider, we also grieve. We also experience the same loss when with the family. So we want to know and we want to see how their parents are doing. So we initiated a project that's condolence call. We targeted pediatric oncology patients, and the purpose was to provide comfort and identify their ongoing psychological needs. Initially, we used to call them after 30 days or after more than 30 days, because we had to retrieve the data from electronic medical record, or by the personal maintenance of the record. But it would take a lot of time. Like if we have requested for on the 1st May, we will get that on the 30th of May. So it will further create a gap. And so from 2016 to 2020, we had 300 calls, and then we realized that we have a response rate from our parents. Let's analyze that, and let's see that what our services are making difference in their life. Are they being effective? Like, we are using the resources, we are calling them. Are they serving any purpose to them? So we analyzed the data, and after analyzing that data, we realized that we need to kind of minimize the gap between the child's death and the call we make after their death, and we need to develop a proper structure program, because initially this call was to just to know that how they are doing, and to offer condolence. But we then planned that there should be some sort of clinical aspect to them, because we are psychologists, we are social worker, we are providing services to them. So what are the services as a clinical provider we can offer to them? So then we prepared a structured script for them. And we started following that script. The first changes we implemented was we reduced the gap of the call, and then we established a palliative care patients registry so that we can get data timely. So we don't have to wait electronic medical records so that they provide data after ages. So we will have the access to the data, and then we can call after 15 days. And then we started doing calls from a scripted condolence calls. So initial insights led to the development of a standardized script. So when we developed the standardized script, it has 4 elements. Number one was addressing willingness to talk. आप क्या हमसे अभी हमने ताज़ियत के लिए बात की कॉल की है, क्या आप अभी हमसे बात करना चाहते हैं? देन वाज अगर वो बात करना चाहते होते थे तो देन विल ऑफर आवर कंडोलेंसेस इंडस हॉस्पिटल की तरफ से हम ताज़ियत का इजहार करते हैं. एंड देन वी यूज टू एड्रेस देयर इमोशनल सफरिंग. So I'll show, we'll explore that. Many patients, जब बच्चे का इंतकाल होता है तो बहुत सारे वालिदैन मुख्तलिफ एहसास से गुजर रहे होते हैं. तो आप बताएंगे कि आप इन वक्त में किस तरह के एहसास का करना. If they wanted to share, we'll welcome them. If they don't want, so we will move to the next question. And the fourth element was exploring their coping mechanism. So if the patient is suffering or even deeply disturbed, so we will think of providing some clinical services as a follow-up. And we made 50 calls with new structured approach. And from that, we got different themes. First one, there was a challenge, communication issues. We used to call them. So the number was not right, or maybe the powered off. And sometimes they won't understand our language because they are from Afghanistan, Iran, Quetta, and Sindh. So there were some communication challenges. Some of the responses had gratitude and support for the treatment or care provided in this hospital, and towards the call we made that we did not forget them, and we still remember them and we care them. So the other another thing was acceptance of flaws. So we identified that the families have acceptance toward loss, grief and pain, and emotional mothers on peers. I have 2 minutes. Oh, just quickly. Just give me 1 minute, sure. So this is the data. So we can see the 25 of the patients. So our figures in the grief and pains are like still 23%. The families, although the acceptance of loss is there, but still the number for grief and pain is higher. So these are some responses. These are some scripted, the old one and the new one we prepared. And so our initiative helped us understand that even a simple call can make a difference in their life, and they would feel better and connected. And specifically, we need to develop services for mothers because they are deeply disturbed. So we hope that these sort of services should be provided at the national level, and we could provide more training to the staff to provide bereavement outreach services. So I acknowledge Ms. Razia Waheed. She is late. Okay, thank you so much. No problem.
Very well presented, Asma. I just have one question. Can you please summarize the points which made you reduce the time gap between the calls?
So it was based on our personal experiences and on base of literature. If we used to call them after 30 days, so that connection, and we are calling them, after 30 or 40 days, So it was at a healthcare level, they would, we are maybe, recalling or refreshing their pain, number one. And the literature says that as soon as you call the patients, that is more helpful for them because, you haven't forgotten them. And yeah, so because if we'll get further longer the time, so then we, because we have a number of patients in a month, we'll have 30 plus patients, so it will further longer that thing. I hope I answered the question.
Yes, you did. Well done.
Thank you so much. Yeah. Oh, Yeah. So the one I mentioned, number off, powered off. We major of the chunk is at Indus Hospital is coming from Afghanistan. So their number, local numbers were also different. Also the language barrier, because if I'm Urdu speaking or I'm a Punjabi speaking, if I'm calling to मैंने कल ही जो है एक सिंधी मदर से बात की, तो उनको मैंने समझने में एक चैलेंज आ रहा था, but they were still like she was trying to manage. So these were the major challenges. Initially we used to had the data problem that we couldn't get data on time, but then we managed it out with that.
Thank you.
Thank you.
So our next presenter is Dr. Akib Sultan, and his topic is evaluation of in vitro activity of ceftazidime avibactam against carbapenem resistance enterobacterialis. Is he here? Dr. Akib. Okay, so he's not here. So moving on to the next presentation, which will be presented by Dr. Faizan Amir. The topic is gametocytic differentiation in IDH mutant astrocytomas, a demographic and survival analysis.
Assalamu alaikum. I am Dr. Faizan Amir. I am a fellow in surgical pathology at Shaukat Khanum Hospital, Lahore. I'll be discussing my publication. It's titled as Gametocytic Differentiation in IDH Mutant Astrocytomas, a Demographic and Survival Analysis. So I have no conflicts of interest or financial disclosures to declare. So beginning with a brief introduction to this topic, the classification of glial tumors has undergone extensive changes within the past few years. And the recent 2021 WHO classification has evolved from a purely histological classification to one that also incorporates genotypic subtyping into the classification system. And the IDH gene mutations are now the hallmark of the new classification system of adult gliomas. So the new classification of adult type diffuse gliomas includes IDH mutant astrocytomas, the IDH mutant oligodendroglioma, and the IDH wild type glioblastoma. These are the three major categories of adult type gliomas. So IDH stands for isocitrate dehydrogenase, which is a Krebs cycle enzyme that converts isocitrate into alpha ketoglutarate. So this enzyme has actually three isoenzymes, with the IDH1 and IDH2 being the main enzymes involved in the development of gliomas in humans. And the TCA cycle normally produces NADPH, which is a rapid form of cellular energy for cellular metabolism. And IDH gene mutations cause excessive production of oncometabolites and a decreased production in the NADPH levels. The consequences of these metabolites are numerous, including DNA hypermethylation, silenced gene expression, and increased susceptibility to oxidative stress. And this basically drives gliomagenesis. And IDH mutant tumors generally tend to have a better prognosis as compared to their wild type counterparts. So an IDH mutant astrocytoma is defined as an infiltrative glioma made up of neoplastic astrocytes which diffusely invade neural tissue. It is one of the most common type of brain tumors in adults. It is usually graded as grade 2 to 4. And the tumor is characterized by IDH gene mutations with frequent co-mutations of the ATRX and p53 genes. So this is the classic histological picture of an infiltrative astrocytoma. So IDH mutant astrocytoma with gametocytes. This is a rare histological variant of an IDH mutant astrocytoma, and it is now the only recognized histological variant in the new classification system. The gametocyte is a large cell with voluminous eosinophilic cytoplasm and an eccentrically placed nucleus. And at least 20% of the cell population of a tumor must comprise gametocytes to be labeled as the dominant tissue pattern. So this is what gametocytes look like. These are large plump cells with bright eosinophilic cytoplasm and eccentrically placed nuclei. So some studies have shown that gametocytic differentiation may be associated with a worse prognosis in these tumors. However, this data is very limited and the actual clinical association is not known. So the aim of this study is to assess the role of gametocytic differentiation in IDH mutant astrocytomas. And so the study was conducted in the pathology department of Shaukat Khanum Hospital. A waiver of informed consent was signed from the IRB. Cases diagnosed between 2005 to 2020 were included in the study. The clinical data was obtained via hospital records and via telephone conversations with the patients. And the histology slides were independently reviewed by two pathologists. IDH immunohistochemistry was performed on selected cases in which it had not been done at the initial sign-out, and the IDH BioSB 132 clone was used for the immunohistochemistry. And the Ki67 proliferation index was assessed in both groups, and the statistical analysis was performed on the SPSS software. So this is what IDH immunohistochemistry looks like. Here we interpret this as strong diffuse nuclear and cytoplasmic staining. And the inclusion and exclusion criteria included all cases which had classic histological features. All tumors had to be grade 2 histologically. They had to show satisfactory IDH immunohistochemistry results, and I had to have adequate clinical data. Any cases not meeting these criteria were excluded from the study. So moving to the demographics, we had 28 cases in both groups. The IDH mutant gametocytic astrocytoma group showed a male predominance. The mean age was approximately 35 years in both age groups, and most of the tumors occur in the cerebral hemispheres, predominantly within the frontal lobes. So this is, again, a classic picture of an infiltrating astrocytoma with a strong and diffuse IDH1. In C, this is the ATRX immunostain, which is a useful stain to diagnose these tumors and shows a loss of expression in the tumor cells with a positive internal control within blood vessels. And this group had a mean Ki67 of 2%. This is the IDH mutant gametocytic astrocytoma group with strong IDH immunopositivity and a mean Ki67 of approximately 4.4%. And some of the tumors with gametocytic differentiation may show perivascular lymphoid aggregates. So moving to the survival analysis, only 8 patients were alive at the start of the study in the IDH mutant gametocytic astrocytoma group, while 16 patients were alive in the IDH mutant astrocytoma group. The mean survival period in the gametocytic group was 2 years as compared to 6 years in the classic variant. And the 5-year survival period was 30% in the gametocytic group and 60% in the IDH mutant group. So this was clinically significant with a p-value of 0.005. Many patients had received adjuvant therapy in both groups, and this was associated with a clinically significant increase in survival time. And the percentage of gametocytes and perivascular lymph node aggregates did not correlate with survival time. So this is a Kaplan-Meier plot. In the blue line, we have the IDH mutant classic group, and in the green line, we have the gametocytic group. So we can see that at the 5-year survival time, we have only 30% patients were alive in the gametocytic group, while approximately 60% patients were still alive in the IDH mutant astrocytoma group. And this is the plot for adjuvant therapy. And patients who had received adjuvant therapy showed a significant increase in survival time as shown in the green graph. So several studies have been published on gametocytic astrocytomas in different populations. There was a study in the Indian population on the top by Avinder et al. This was about the histomorphology and proliferative potential of these tumors. And then there was a study in Switzerland on the incidence and survival rates of these tumors, and another study on the significance of gametocytes and astrocytomas in South Korea. So if we do a comparative analysis, the mean age of presentation in our group was similar to the one in Indian population at around 35 years, but the patients in the Swiss population had a higher mean age at presentation at approximately 50 years. The mean survival time in gametocytic astrocytomas in our population was 2 years, and this was significantly less than the one in Switzerland and in South Korea. While the IDH mutant astrocytoma group showed a similar survival period in different populations. And our survival period, 5-year survival period was 30%. This was again less than the one in Switzerland and in South Korea. So what could be the reasons behind the poor prognosis in our population? Some of the patients present late to the clinician in our population. The treatment options that we have available are very expensive and may not be available to everyone. And patients generally tend to have a poor clinical follow-up in our presentation. So what could be the molecular causes of poor prognosis? Some recently published articles have shown that mutations in the CCND2, which is cyclin D2 gene, may be associated with gametocytic histology in these tumors. And the amplification of this gene may have an adverse prognostic factor in these tumors. So these recently described mutations may be the key prognostic factors in these tumors, and frequent p53 mutant expression in IDH mutant gametocytic astrocytomas may also be associated with a poor prognosis. So in conclusion, gametocytic differentiation in IDH mutant astrocytomas is associated with a worse prognosis and a short survival time. And additional mutations have been described which may be associated with a poor prognosis. These tumors tend to have a higher Ki67 index, and this subtype should be mentioned in histopathology reports to provide a better prognostic information. Some of the limitations of the study included a retrospective study design, the limited number of cases available, the limited details of the nature and duration of the adjuvant therapy, and inavailability of CCND2 genetic analysis. Thank you.
Thank you, Dr. Fazan. Very concise and very easy to understand your presentation was, and I can see the effort you put into it. I just have one question. Can you please tell me that your study included only grade 2 gliomas, lower grade gliomas?
Yeah, absolutely.
So you have no experience of the relationship of gamestocytic differentiation between the grades of grade 2, 3, and 4 astrocytomas, right?
Yeah, so this study design was basically only on tumors which had a low grade histology, and we had excluded all tumors with of grade 3 and grade 4 because by nature those are aggressive tumors. So that would be so if we included those in our study, they would be automatically skewing our results. So our study design basically only included studies that were low grade as proven on histology.
And in your experience, do you see gamestocytic differentiation in tumors other than lower grade astrocytomas like oligodendrogliomas or other?
Yes, so gamestocytic differentiation can be seen in nearly all gliomas of all different grades. So it's a very prevalent, that's a rare histological pattern, but it can be seen in all sorts of gliomas.
Okay, thank you. Thank you. So our next presenter is Dr. Nida Babar. She will be presenting the paper on role of CATA3 and STAT6 immunohistochemistry in classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma.
Assalamualaikum. Greetings to everyone present here and also the Zoom fellows. The topic of my presentation today is based on my article studying the role of CATA3 and STAT6 IHC stains in classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. I declare no conflict of interest on any financial association with any organization. Briefly, the epidemiology. Hodgkin lymphoma is ranked the sixth most common malignancy globally. In Pakistan, it comprises 4.9% of all malignancies. The term Hodgkin lymphoma in current WHO classification contains two distinct entities, classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Both are derived from germinal center or post-germinal center B cells. On the left side, you can see a mixed cellularity classic Hodgkin lymphoma cells, which show iconic Reed-Sternberg cells, some mononucleated, some binucleated, embedded in a milieu of reactive immune cells. While on the right side is an image of LP Hodgkin lymphoma, which shows the multilobated LP or popcorn cells, multinucleated, and they are usually embedded in nodules rich in germinal center B cells and follicular dendritic cells. Patients are usually diagnosed in their early adulthood, and lymphadenopathy with B symptoms is the most common presentation. But there is ample clinical pathological and etiological evidence that NLPHL is a different neoplasm from classic Hodgkin lymphoma. So much so that WHO is even considering removing it from the category of Hodgkin lymphoma and instead placing it under the category of mature B-cell neoplasms. Both have different treatment modalities. More than 80% patients of classic Hodgkin lymphoma are cured with modern polychemotherapy, selectively combined with radiation therapy. But in case of NLPHL, children with limited stage disease, only watchful waiting after resection is employed. For adults with limited stage disease, radiation therapy or chemotherapy is given, and only patients with advanced stage disease are treated with systemic therapy. As I have already mentioned, they are derived from germinal center B cells. But by the time Hodgkin lymphoma is diagnosed, the Reed-Sternberg cells show remarkable aberrance at the morphological level, and they have mostly lost their B cell phenotype. The only B cell marker showing its origin from B cell is weak expression of PAX5. Otherwise, pan B cell markers like CD20, CD79A are mostly negative but can be positive. They are positive for CD30, CD15, and EBER. While in case of NLPHL, these cells show pan B cell markers like CD20, CD79, and OCT2, and CD30, 15, and EBER are negative in NLPHL. Although their diagnosis is straightforward in most cases, occasional cases pose diagnostic challenge. For instance, the lymphocyte-rich subtype of classic Hodgkin lymphoma, whose image is shown here, is very much morphologically like NLPHL, and the B cell B cell transcription factors are more frequently expressed in this subtype than in other classic Hodgkin lymphoma subtypes. Also, Hodgkin lymphoma can be PAX5 negative, and the diagnosis of PAX5 negative classic Hodgkin lymphoma should be made with caution. On the other hand, CD20 and one or more of B cell transcription factor markers like BOB1, OP2 may be lost in rare cases of NLPHL. Also, CD19, which is a B cell marker, is frequently negative in NLPHL. Hodgkin and Reed-Stubbs cells produce several cytokines, creating their own reactive microenvironment, which contributes to their survival and overall evasion from host immune response. One of them is STAT6 from STAT family of transcription factors, which is activated by interleukin 13 and 13R, both of which are expressed by Hodgkin lymphoma cells. Another factor is GETA3, which is a T cell transcription factor, and its aberrant expression has been seen in classic Hodgkin lymphoma through gene expression profiles. So our main objective was to study the utility of GETA3 and STAT6 IHC stains in differentiating classic Hodgkin lymphoma from NLPHL. We selected the database of Shaukat Khanum Hospital. Now using Yemen's method with confidence level 95%, we selected the sample size of 94, of which 79 patients were of classic Hodgkin lymphoma and 15 patients were of NLPHL. After approval from hospital's institutional review board, all 94 cases were reviewed independently by 2 hematopathologists. One slide per case was stained separately with GETA3 and STAT6. Isolated nuclear expression or dual nuclear and cytoplasmic expression was required to consider the expression positive, while no staining or only cytoplasmic expression was considered negative. For GETA3, cases of breast carcinoma served as external control, while for STAT6, cases of solitary fibrous tumor served as external control, and background small lymphocytes served as internal control for both. For inferential data analysis, Fisher exact test using SPSS software was applied. Significance was set at less than 0.05. Inclusion criteria included all diagnosed cases of classic Hodgkin lymphoma and NLPHL by histology and IHC in SKM hospital. Exclusion criteria included all those cases showing extensive necrosis, limited tissue, poor fixation, or minimal or atypical infiltrate. A total of 65 male and 29 female patients were selected. Age range varied from 3 years to 69 years. Lymph node site varied, including axilla, cervical, mediastinal, sublingual, submental, and paraiotic. Intensity of staining varied from weak to strong positive. Percentage of positive cells ranged from 5 to 95%. This table shows the results of GETA3 in both tumors. As you can see, in case of classic Hodgkin lymphoma, 75 out of 79 patients were positive, while only 4 out of 79 patients were negative. While in case of NLPHL, none of the case was positive for GETA3, while all 15 cases were negative. 12 showed no staining, and 3 showed only cytoplasmic staining. The p-value turned out to be less than 0.001. On the left side, you can see classic Hodgkin lymphoma Reed-Sternberg cells showing intense nuclear staining for GETA3, while on the left side, you can see LP cells showing negative staining for GETA3. These are the results of STAT6 IHC. In case of classic Hodgkin lymphoma, 65 out of 79 patients were positive. Percentage positive cells were 82%, and 14 cases were negative. 6 showed no staining and 8 showed only cytoplasmic staining. While in case of NLPHL, only 1 case was positive and all rest of the 14 were negative. 9 showed no staining and 5 showed only cytoplasmic blush. The p-value in case of STAT6 also turned out to be less than 0.001. This image shows classic Hodgkin lymphoma Reed-Sternberg cells showing nuclear staining for STAT6, and this image shows LP cells showing negative staining for STAT6. These are the results of Fisher exact test of our study. Our value was less than 0.00, and Fisher exact test shows a p-value less than 0.00 when there is association between variables. So in a nutshell, the distinct natural history, biology, prognosis, and treatment modalities between classic Hodgkin lymphoma and NLPHL obviates the need to accurately diagnose these two entities on tissue biopsy in both upfront and relapsed cases. In a study conducted by Kaislarian et al., GETA3 nuclear expression was suggestive of classic Hodgkin lymphoma and ruled out NLPHL with 100% negative predictive value. Similarly, in another study conducted by Schneider et al., the authors examined STAT6 nuclear expression in almost 80% cases of classic Hodgkin lymphoma. An important limiting factor to consider here is that both these antibodies work best when the tissue is optimally fixed. And in suboptimally fixed areas of larger biopsies and in older biopsies, they show poor sensitivity. Therefore, the age and fixation status of tissue should be kept in mind while using GETA3 and STAT6 IHC stains in diagnostic pathology. In conclusion, nuclear expression of GETA3 and STAT6 is helpful in accurate distinction between classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Thank you.
Nicely presented, Dr. Nida. Dr. Nida, according to your research, are these markers being used currently for this purpose as a regular marker, I mean?
The routine IHCs are, as I mentioned in the slide, are CD30, 15, PAX5, and EBER. But in occasional cases, which post-diagnostic challenge, these markers can be used. Even WHO, after my research, after I had done my research in 2022, WHO classification, they have included GETA3 IHC stain in diagnosing classic Hodgkin lymphoma, and they have said that this GETA3 stain can be used to differentiate it from NLPHN and other related entities.
Okay, that's a very informative point. Thank you.
Thank you.
So with this, we conclude our session. Thank you everyone for joining us.